Hello everyone, this will begin the voiceover for the second portion of acid-base balance, introduction to the respiratory system. We've already completed the renal system, so we will now finish with the respiratory system as we talk about the acid-base balance within our body. The respiratory tract anatomy, just a brief overview. It does begin with the mouth. As you inhale, air, oxygen, will go down the back of the mouth, which you see is the pharynx. Sometimes we'll refer to that as the oral pharyngeal area. If we go further down that respiratory tract, we will then reach the trachea, and you will hear that as a sometimes if we suction or we have a device, you'll hear it orotracheal or nasotracheal, meaning because you do breathe through your nose, so sometimes if a tube goes through your nose and it goes down as far as the trachea, it will be referred to as nasotracheal or orotracheal. As the respiratory tract progresses down, we will hit the main stem bronchus, where we will then break off to the right and left. And typically, as you go down the trachea, you do have a likelihood of any kind of tubes will want to, if continuing to go forward, may end up going into the right main, more so than the left. And the same thing arises when we talk about pneumonia. If an individual ends up having some issues with swallowing, and that happens with medical conditions, or as one gets older and muscle weakness occurs, sometimes what they consume orally can end up going down the wrong pipe, as my grandmother would say, and therefore that would then go into the right main. The likelihood of it going into the right main is more prevalent, and that's why usually you'll see a what's called a right lower lobe pneumonia. So the likelihood of that is greater. Now, we do have little devices within our body to protect our airway. Okay, so we do have our epiglottis, so that's going to help with opening and closing, so that when we do eat, food goes down the esophagus into the stomach versus going into our lungs. We talk about normal flora. There's normal flora within the lung cavity, and typically, if anything other than the normal flora gets down there, that's a wonderful, dark, moist place for organisms to multiply. So what we want to do is keep the normal flora there. So we need to, as you get into nursing and you'll learn various skills, sterility, it becomes important, because as you put certain tubes and devices, if they're going that far down into the respiratory tract, you do want to maintain a form of sterility with our suctioning, because we don't want to keep introducing organisms there. Now, there are times when we do what's called a bronchoscopy and we go down into the lungs, and again, that's not necessarily a sterile procedure. There's an issue going on. There's, it's probably pneumonia, organisms, etc., and they're going down there to probably clean out the respiratory tract, try to remove some of the organisms. And there are certain times, because of issues going on, that we will even do biopsies that way. But again, for us as nursing, when we tend to want to suction, we do want to maintain sterility of the catheter, and that's only to minimize the introduction of outside organisms into the lung that typically are not found there. You also have protective mechanisms within the upper airway. You've got cilia, hairs on your nose. The cilia not only goes in the nasal cavity, but that hair-like structure will also proceed down the airway, because with that will be mucus production. I mean, mucus is good lubrication, but you will have increase in mucus production when an invading organism enters the cavity, because the body's identifying this, and production of mucus will increase in order to grab onto the organism. And then the hair-like structures known as the cilia will then work in a opposite fashion to try to then take this engulfed organism and push it upward, so that you can cough and expectorate it and remove it. So I think the body's pretty amazing when we take a look at that. As we look on future slides, the oxygen that you do inhale will go all the way down into the bronchus, all the way down, and we'll see the alveoli on future slides where we have our gas exchange occurring. Okay, oxygen will cross over, get into our bloodstream, and therefore our body will also be removing wastes, and that waste product is CO2, carbon dioxide, and that will occur when one exhales. And again, we spoke of that gas being very acidic. Okay, so CO2 does lead to an acidic environment if retained. As you look on this picture, you'll see the diaphragm at the bottom. Again, a muscle necessary to help the lungs inflate and deflate. So if you have any compromise in the abdomen, say abdominal distension, the abdomen's getting bigger for whatever reason, or possibly you've had surgery, you've got pain and it's difficult for you, with your abdomen, because if it's hard for you to move and get that muscle moving up and down, whether it's distension or you're having pain because you've had surgery, it impairs the lungs' ability to inflate and deflate. And that's where we run into some issues with acid-base imbalances going on. Okay, and this will be sometimes, we'll see where our body's going to try to correct itself through the buffering system of the kidney, since the lungs and the kidney are kind of like sister and brother, and they help each other out to maintain homeostasis. It's when the body is going to need help from us that we start to see the abnormal values in our blood work. Well, we also see the signs in the patient so that we can intervene. So we're going to talk about medications that are going to help in many ways with gas exchange, and to just help with other medical conditions to get that oxygen where it needs to go. Here is another diagram of the upper respiratory tract. Again, you'll see the nasopharynx, oropharynx. Again, this is just terminology I'm just talking to you about. So if you've read it or you'll hear somebody talk about it, you'll kind of connect to that. The laryngeal area, laryngopharynx. You will hear some issues going on with the larynx. And if you look to the picture on the bottom right under larynx, you'll see the epiglottis. That's our flap. There's a condition called epiglottitis. Again, anything that ends in itis means inflammation. So if we have an inflammation going on within the epiglottis, that's our protective flap. You can see where there could be some issues going on with items not going where they need to go. And not only that, how about oxygen that you're inhaling, or if you're getting oxygen, it becomes difficult for it to get down the trachea, which you can see the trachea has the little lines there, or the cartilage, the little ribbing. So that would be your trachea. And just take notice, this is just a nice picture, to the esophagus, that very skinny tube that goes right behind the trachea. So if you take a look, it kind of goes down, it narrows. The trachea also in a young child is very narrowed. In this picture it is bigger, but it's amazing in a child to think that their airway is really as big as an eraser at the end of a pencil. So it's very, very narrow. That's why respiratory conditions, congestion, is important for us with children, because the congestion's blocking, gas exchange of oxygen. Where for us, we have a bigger tube, a bigger size trachea in diameter. So, we're able to get the oxygen to go past the mucus. Also with a child, the distance between the oral and the lung is closer. For the adult, it's further apart. So that gives a little bit more of an area of displacement. Now, for the adult, the area that we're going to talk about when it comes to gas exchange would be certain lung conditions, such as COPD, briefly touch base on a little bit of asthma, kind of go over some congestion that occurs with bronchitis, and how that, added to other conditions of the airway, will then pose a problem for one. And that's why we have the medications that we can give you. So features of our upper airway tract, again, preventative features. We've got hair, the cilia, which is wonderful. Goblet cells, again, making the mucus production when we need to. Again, it's all about lubrication, and it's all already there. to react to invading organisms. So that's why you do, when you get sick, you produce a lot of mucus. The blood supply when we breathe is warm, okay, and there's moisture to it. So if you're out skiing or doing anything in the winter and you kind of put your scarf up over your mouth when you're breathing, you kind of notice the moisture on the scarf. Your face can get wet. And sometimes little kids, when they're out playing and you do that, like they get their face all red because it gets moist. And it can be irritating to the skin, but that's just so you can identify there's humidity going on when one breathes and the air is warm. So in medicine, if I'm doing and supplementing oxygen to you, and we're talking about oxygen that's going further down, not nasal cannula, not those little prongs that go into your nose or, a mask, but we're talking about if the patient has a hole in their neck where the trachea is, and they call that a tracheostomy. We do provide moisture, moisture to that oxygen. So sometimes we refer to it as a bubbler, but we have to add moisture to the oxygen that we give to the patient. Also, if they're on a ventilator or any kind of assistive device, we do warm. We warm the oxygen that we're giving the patient, and there's also areas on those devices where respiratory will add sterile water to provide humidity. So that's an important feature that we as a human being have. But if we have issues, medical issues, we have to remember, if we're not breathing through our mouth, we're not going to get that oral from the upper respiratory, we're not getting that moisture, we're not getting that warmth, we have to supply that to the patient. And that will also help the gas exchange movement. And our brain has wonderful devices instilled that will be stimulated when these receptor sites are tickled and we have a cough, cough and a sneeze reflex, that will elicit those responses. All right, and these are actually prompted within the central nervous system, within the brain. So it's difficult for a little baby to have the appropriate receptors and the CNS all matured at the same time. Of course, they're developing. It's not going to be. So little kids have a hard time. They don't cough. So when little babies sneeze, that's actually the reflex trying to help them clear their airway. It's not that, oh boy, they're sneezing, they're getting a cold, but it's just their way of clearing the mucus, which for many of us as mothers, we remember when our kids were little, we had that little bulb syringe, and we would kind of have to suction and clean out their nose a lot. They do sneeze, but kids don't cough when they're that little. So we kind of have to just keep an eye. That's why that happens. If anybody has a head injury where we have damage to the central nervous system, we do have an impact with the messaging going on with various reflexes, and that is important not only for injury, but also when I give you medication that impairs or depresses our central nervous system, we can depress these safety mechanisms, this cough and sneeze reflex. So that's why when one doesn't have the ability to, if they're not responsive, they can vomit and it can go into their airway. They're not going to cough. They're not alert enough to have the receptor site pass the message along to the central nervous system and then have reaction occur. So again, that's central nervous system depression. So that's why it's real important. People don't realize that when they take medications or consuming alcohol toxicity. And then for us as nurses, receiving anyone from who's received anesthesia, or maybe if we are administering something that could be a central nervous system depressant, we always have to watch that the patient has these reflexes. How do we know? When we check their mouth out, we can use a tongue blade just to see, number one, if they have a gag, which is protective, but we'll also be able to elicit a cough. Tell them to cough. Can they do that? Can they follow commands? So these are protective mechanisms that we need to evaluate. So now you know why. Here's your sneeze and cough reflex that we just mentioned. Again, it's all protective, and it's just the body's way to kind of clear out any congestion that needs to be there, any kind of irritation, something that really is not supposed to be there. Now we're going to move into the lower respiratory tract. And sometimes you will see books and handouts that may delineate the respiratory tract to upper, middle, and lower, but a lot of times just upper and lower because it's a different environment. Medications may work a little differently or maybe are more prevalent for the lower versus the upper. So just so you're aware. Now this is where we're going to see on this particular slide the alveoli that I had mentioned. So we're moving our way down the mainstem bronchus into the bronchioles, and then we're going into the branch, and therefore at the very end are our little grape-like clusters, which you see on the screen here. They are wrapped around with circulation. See the red, see the blue lines? Okay, those are branches of circulation. That's what's helping a lot with removing wastes. Okay, you do have CO2 in your bloodstream as well as going in and out of the lungs. Okay, so when we damage the alveoli, which you see they look like tiny little bubbles, little grapes, when we ruin them, when we end up having them become dysfunctional, they can turn into one huge alveoli, one huge bubble or one huge grape-like cluster. And the problem with that is the effectiveness of the alveoli is not working. Okay, the gas exchange is going to be grossly impaired. And someone who has destruction of the alveoli like that, they're noted on an x-ray, it will be looking like, it will say emphysemic changes. Okay, because that's what's going on. That's emphysema. And that's why those individuals have a difficult time breathing and moving, because when they move, they increase oxygen demand. They're not able to meet the oxygen demand because they don't have alveoli as you and I in order to facilitate the gas to go across the bloodstream. So therefore, the muscles, the tissues are not getting the oxygen they need, and therefore that's where the body becomes symptomatic. And they show fatigue, and they show shortness of breath with activity. And you've heard me mention this a few times, gas exchange. This is exactly what's really is happening. Okay, we've got our CO2 and our O2 crossing back and forth. Okay, it's a process of diffusion, as you see at the top, diffusion of CO2. It's a way to move the bad out, bring the good in, a way to remove waste products. Our respiratory tract is controlled, again, by the central nervous system. When we talked about medications, narcotics, how it can depress the central nervous system, and that we always have to watch and check and assess that the breathing is adequate before I give you that medication. The patient is not awake and alert enough. The patient looks like they're not breathing well. If their breathing is slower, we also watch the effectiveness of the breathing through a little clip that we can put on the finger. We can put it on the earlobe. It's a way to obtain a number called an oxygen saturation, and that will identify that there's adequate gas exchange going on. But if ever you have to give a medication that can suppress the central nervous system, the patient's not alert enough, or if you feel that they are not breathing adequately, you have that right to hold the medication, call the doctor, or there may be protocol at your institution on your floor already established for protocol that you follow as to what to do. A lot of all hospitals now, to my knowledge, have a component that you just have to pick up the phone and you call an RRT, a rapid response team. Okay, it's important. If there's something that's depressing gas exchange, we can't let that go on, because not only is it inhibiting oxygen, it's inhibiting the CO2 from getting out of the body. And we said that's an acid, and that makes the bloodstream acidic. And when the bloodstream becomes acidic, too acidic above our normal pH, which is 7.35 and set to 7.45, medications don't like to work. And it becomes a crisis. It becomes an emergency. Okay, the heart is irritable if it doesn't get oxygen. The brain can suffer damage. Okay, so a lot can go on. So now when we look at the next bullet, and it says respirations depend on a balance between the sympathetic and parasympathetic systems, you can appreciate those two systems. Now that we've talked about the autonomic nervous system and we've dissected both of those, now you can see where our medications are going to target the sympathetic nervous system, because it promotes bronchial dilation, okay, which is going to help the airway, help our gas exchange. Now, the parasympathetic Again, we'll stimulate the diaphragm contraction, and that's the muscle that's necessary for the lungs to be able to move and inflate and deflate. We also have nerves in our body. The vagus nerve is one that will stimulate bronchial constriction. And the sympathetic nervous system, when it's stimulated, again, someone is chasing you to hurt you. Yeah, you're going to run, your breathing's going to go up, your heart rate's going to go up, your blood pressure's going to go up, the sugar that's available in your bloodstream is going to go up to give energy. Dilation in the lungs is going to happen in order to get gas exchange to all those muscles in order for you to get away. Okay, there's your fight and flight. Just a quick review. Upper respiratory tract. These are the conditions now that we're going to talk. Briefly, we're going to talk about these. All of these conditions that you see here, you will spend some time on when you get into Nursing 120. So it would be your spring semester of your first year. Okay, so we're just going to talk lightly about them. Like I said, you're going to talk in depthly about them. This is the nursing pharmacology, so we're just letting you know these are the conditions that we're going to be giving the medications to help one's breathing, and these are the reasons why. Okay, so the common cold, we do realize we're not going to rush in and give everybody antibiotics because these are viral pathogens. You let the virus run its course. It's the bacterial pathogens that warrant the antibiotic. So just treat the symptoms with the common cold. Okay, do you have stuffy nose? Do you have a runny nose? Do you have aches, pains? Treat the system. Do things to help the problem. Put a humidifier in the bedroom. Sometimes you've heard of herbal remedies where you put the lavender on the feet. I've even heard people say that Vicks Vapor Rub, which I love. I always put that on under my nose. I've heard people say you put that on your feet and you put on the bottom of your feet and you put your socks on, and that will disseminate the medication. It's kind of eucalyptic, and it kind of opens up the pathways. My husband has a remedy for a stuffy nose. His remedy is super hot chicken wings. He goes, that opens up the nasal passage every time. But anyway, whatever works for you. I swear by the vaporizer. The minute I start to get congested, I put a vaporizer in the bedroom, and I've always done that for the kids. It provides moist air, as we said, and if you can't breathe through your nose and you become a mouth breather, it's wonderful to have that moist air as you breathe, and it does help help open up things. I mean, how about a nice shower, right? A nice steamy hot shower. As you get down the seasonal rhinitis, that's your nose, okay? Allergens causing inflammation to the nose, to the pathway, okay? Stuffy nose. Sinusitis, the sinuses, those are the cavities behind the like the cheekbone. Okay, they typically don't expand, so that's why you get a lot of pressure in the sinuses when you have that inflammation going on from any kind of foreign matter. Okay, you don't want that infection to be untreated or to go on without treatment. Some patients have to have their sinuses tapped. The biggest concern for us is it's very close to the brain. Okay, so you don't want any of those pathogens to be able to travel, and eventually, if anything becomes weakened, you don't want that to get to the brain because that's very serious. We know it's difficult to get antibiotics through the blood-brain pathway. We've got epiglottitis, inflammation of the epiglottis, which we know is a wonderful protective component. Now, this is bacterial, and yes, you'd say, antibiotics, but we don't see epiglottitis rarely, if any, because this is an infection from the Haemophilus influenza. And we actually immunize children for this. It's very important for a child. If they get epiglottitis, that airway can close off quickly, and the child will go into respiratory arrest. And if you think I'm going to put them in the car and just drive them there, once they get there, there's such swelling going on that, unfortunately, many years ago, a lot of children died. Little kids died just because they couldn't breathe. And it's very, very tragic, but we have eradicated this to the point that this condition that we do give immunizations. So, but I know people don't want to take immunizations, so we always are on the watch. But again, it's important, and you're going to learn all about that when you learn about the kids and the airway, how important that is. And speaking of organisms, take notice on the side of this slide. You'll see the microbiology component. It will tell you the organisms that cause the various conditions. So we'll look up at the right-hand corner and we see otitis media. So that's ear infections. And so you can take a look and see those organisms that are up there. Again, otitis media can be caused from many issues. And again, children typically outgrow that over time as their tubes in their ears will angle and allow drainage. So there's our sinusitis. There's croup. Croup is a very tight, horsey kind of a cough. And how we typically treat croup. Years ago, kids would be in the hospital and you'd have this like plastic tent over their crib, and it was all moisture, to try to moisten things up and to get the airway opened up. You don't see that as much anymore. Parents have learned to treat their child. Again, we can give some steroids for that inflammation that's going on, but get them out into the cold. Take them out on the porch at night, because usually in the wintertime you see this happening. Take them into the shower. Again, that will help open that up, And then the epiglottitis, again, we don't often see that anymore, thank goodness. Whooping cough coming back around, so we do see some issues going on with that, with some immunizations. The bronchitis and the bronchiolitis, this respiratory syncytial virus, or RSV, we as adults can acquire that. We can get that. That's a cold. Okay, that's just a virus. We tend to be able to battle it. But children that have RSV, we typically will have them hospitalized because, again, we're worried about their airway. It's not necessarily because they need antibiotics. It's the airway. It's a viral infection. But we worry the severity, the mucus, the narrowing of the airway. Okay, we don't want anything to happen to the little one. So then up on the left-hand side, the common cold. Okay, we do see the coronavirus. Again, these are all viral, but we do try to minimize if anyone has any of these kind of issues going on in the hospital. We will culture them up. They may put you in isolation in order to protect the spread of it from other patients. We don't want to be a carrier and spread it. Moving on down, dental, okay, the mouth. You don't realize the bacteria that one has in their mouth. Okay, so you've got the organisms going on there, and we'll talk about mouth care as we go through some of the medications. And pharyngitis, again, you saw the slides on the earlier when we talked about the oral pharyngeal area, so that's like the back of your throat. So someone who has pharyngitis, inflammation of the pharynx, again, that's just a really super bad sore throat. And again, if someone has it, we are going to culture the throat. We're going to do a rapid strep, etc. We're going to see what's going on. How do we need to treat that? Do we need to do antibiotics for that? Okay, so we do want to evaluate that. Is it viral or is it bacterial? And then you've got your laryngitis. Again, inflammation of the larynx. You always hear people, hard time talking. They've got a frog in their throat. Again, is it persistent? How long have you had it? Is it recovering? We're going to treat it through moisture, etc. And again, we want to rule out viral or bacterial because, again, that's going to impact what we give you. The lower respiratory tract. These are conditions. Atelectasis is a big condition. It's the collapse of the alveoli. As you take a look to the left, and you'll see all the different conditions, how it impacts the alveoli. It does impact your gas exchange. We're worried about atelectasis when patients have surgery. Anyone who's not able to take nice deep breaths. As you see the picture here under the word tract and condition, this is the right lung. And we can tell that because there's 1, 2, 3 segments in the right lung. The left only has 2. So when one inhales, they need to do so deeply so that all of those segments, those portions of the lung will open up. It's not that the lung is one big unit. It has to open up. And it depends on how deep of a breath you take. We also refer to as the inspiratory effort, right? If someone's fatigued, someone's over-medicated, or maybe just medicated, and they're just really sleepy from the medication, they will have a deep inspiratory effort. We have to try to get them to take deep breaths because if we don't, collapse of the alveoli can occur, and that's atelectasis. We can see that on an x-ray. So we have this lovely, lovely respiratory tool that all the patients get in the hospital, and they call it incentive spirometry. So there's two types out there. There's one where you inhale, you put the mouthpiece in, and it's like you're drinking through the straw. You take a nice deep breath in, and you will see the accordion device inside there elevate, and it will tell you how many milliliters you've inhaled. And then there's also another one where it's 3 balls, they're different colors, and you kind of estimate the volume based upon how many balls can be raised up when they take a deep breath. So it's a nice measuring tool, lets the patient participate in the care, lets the patient also see progress. Okay, and again, sometimes right after surgery, it's hard for them to even get the first ball up. So what we like to do, if we have that opportunity, let's teach the patient how to do incentive spirometry before surgery, so they know how to do it. It's very hard to teach someone how to do something when they're uncomfortable and they're in pain, to try to coordinate, because you don't realize how many abdominal muscles you do use when you need to take a deep breath. There are other issues that can cause the collapse of the alveoli or the dysfunction of the alveoli's ability. And as you move down, you can see pulmonary tumors can impact, pneumothorax, which is a collapsed lung. We've got pleural effusions going on. And that, again, these are the conditions that you're going to learn about when you get into nursing. These are conditions that will inhibit the lungs, inhibit the patient from taking deep breaths. Again, we can see these things on x-rays. Pneumonia, again, we realize it's viral or bacterial. We need to identify it. And again, when we have congestion down in those lungs, we've got impaired gas exchange. It's just like swimming in the ocean. It's real easy to swim in the ocean when there's a low tide. When it's high tide and those waves are whipping in, it's really hard to swim through that water. Think of yourself as the oxygen molecule. When you have a lot of congestion to go through, it's going to take some time. You're not going to get as many oxygen molecules down there. Bronchitis, again, inflammation of the bronchiole. Again, we're narrowing, all the way down, narrowing mucus production. So you're kind of getting the gist of it. Bronchiectasis, again, a chronic inflammation that goes on down in the bronchioles. And then we have this obstructive pulmonary disease. I just want you to know asthma has been removed recently. It is no longer an obstructive pulmonary disease. Asthma has its own area to go into now. But we do put COPD, and I think your book goes over the respiratory distress syndrome, and you'll learn about cystic fibrosis. Again, these are obstructive, permanent changes. Sometimes kids can outgrow asthma when they're younger, but again, asthma is more about inflammation in the airway versus the obstruction, which would be permanent. Asthma, we can alleviate some of that narrowing through our medications and etc. So they have removed it. They have removed it from the algorithm. So now we're going to talk a little bit about our medications that we're going to be giving one. As you identify the upper respiratory infections, again, what is it we can do to help with the upper respiratory infection? Identify what's going on. What symptom is the individual experiencing with this infection? Is it a stuffy nose? Is it a runny nose? Is it a cough? And how about that cough? Is it moist? Is it dry? How about that cough? Can you bring mucus up or can you not? Just things like, do you have a sore throat? Again, you see this on the news every year when we get into the flu season. They have it to try to educate everybody. Is it viral? Is it bacterial? Is there a sure way? Again, let's identify the symptoms. I know the pediatricians would tell us, when should you come in? That's always a question parents ask the pediatrician. It's also the same question that an adult will ask their doctor if they have other medical conditions going on. Okay, I don't want to run to the doctors all the time. When do you think the time for me to worry? Most people try. We've learned, let's kind of let the cold run its course. Let's see what we can do to help it out. Let's not rush to medications. But then sometimes patients do that, and they just keep getting sicker. And we often say, well, if we had intervened a little bit sooner, it would have made this whole process easier for you. Again, identify what works for you with your medical conditions. But what's happening? Inflammation. Inflammation, we saw that with infection. Infection and immunity, inflammation, those concepts were so close together. Inflammation occurs to get blood flow where it needs to in order to get those white blood cells to get there to attack the infection. With that, you're going to have blood vessel permeability, so that's where you get the swelling going on. Okay, you get the stuffy nose, etc. We already identified why we have increased mucus secretion going on. Now comes the ability, can I have this strength to cough up the mucus? Do I have any other prior existing conditions that make it hard for me to cough out that mucus? And patients that have had strokes, okay, they have weakened muscles throughout. Sometimes it's one side you may see that flaccid or the inability to move the extremities. Well, if that's happening, how about the muscles too inside the body that you can't see? And cough is usually a big one for them. Patients that have had strokes are in and out of the hospital with pneumonia because their cough is not as effective as it was prior to the stroke. So that's important. How about if I have COPD? Okay, I have obstructive narrowing going on. That will also have inflammation. That condition also has chronic mucus. Now, add an infection on top of that. More mucus, more inflammation. These individuals have a really hard time getting mucus out because that airway is so narrowed. It's very hard to get the mucus out. And they're trying to get oxygen in as they're trying to get mucus out. Yeah, it becomes very difficult. We do get a lot of patients in the hospital with what we call exacerbation of COPD. And a lot of times the reason it's aggravated, that COPD condition's aggravated, is because there's an infection going on. And that's all they needed to tip them over to the edge and make them have to come into the hospital because they can't get their air. Now, when we talk about chemical mediators, we're going to address a little bit of the inflammation from prior concept discussion. Don't forget the histamine release that goes on, okay, with the inflammation. All right. So how are we going to treat this? How are we going to treat this upper respiratory infection? Well, what we've got going on is antitussives. That's a nice word. I think it's a nice word. It looks pretty on the paper, huh? Antitussives. These are things that are going to block the cough reflex. So you've got to identify, the doctor has to identify, is this a good patient to block the cough reflex on? Am I going to be okay blocking the cough reflex on this particular patient? Again, some patients, we have to evaluate that. Is the cough that annoying that if I suppress the cough, is that a good thing? I mean, are they in need of bringing up mucus that the cough is necessary? So these are just questions I'm proposing to you just to kind of think about. Decongestants. We see commercials for this. Yes, this got swelling, we've got the edema, blocked nose, etc. It's the decreased blood flow going on, again, because we've got compression, we've got swelling, we've got lots of secretions going on. You're going to find that a lot of these things tend to kind of flow over into another. If I have histamine release with inflammation, the best thing is let's give an antihistamine. Let's block that action, okay? Therefore, we can then open up those narrowed airways, okay? Expectorants. To expectorate is to cough or productively bring up something and clear the airway. Expectorants will cause you to do more of that. So if my mucus is in need to come up and I'm having a hard time, this is going to help me clear it out and then carry that right over to the mucolytics. If my mucus is so thick, and sometimes patients, their mucus can be so thick, it's not moist. Again, remember I told you about the moisture that goes on in the oral airway? Sometimes that can happen. If they have certain respiratory devices at home that may dry their airway out, or if they have a tracheostomy and they're missing that natural component of humidification going on, are they having a hard time getting that mucus out? It can actually harden and turn into a mucus plug and block the airway. That becomes a medical emergency. I've seen it happen at the bedside. It's very scary for the patient, very scary for the family. It's very scary for the nurse, too, when you just get out of school and you're seeing this happen. But if we can identify when the patient coughs up their mucus, we ask them, can I see it? As gross as that may sound, yeah, I want to see it. I want to know what the color looks like. I want to know the amount. And I want to know, is it thin or is it thick? Sometimes the mucus is so bad, it is so hard, it's like choking on a mozzarella cheese stick. And that's your mucus. And how could you ever really cough that up? It is so, well, again, just envision yourself if you had a mozzarella cheese stick. It's gooey, it's stringy. It's not real easy to quickly get the job done. So yeah, we have to give you mucolytics. And you see commercials on TV for the Mucinex guy, thinning the mucus, trying to get it out. We can give you medications in breathing treatments to thin the mucus so the patient can cough it out. Now, if I'm giving you these things, you have to be able to cough, and you have to cough adequately. You have to be alert enough to cough to get this stuff out, okay? Here's a diagram identifying the sites of action for you for the particular medications. If I do want to give one a cough suppressant, because I need to, I can give narcotics, right? Codeine, hydrocodone. We can put codeine in cough medicine. You don't see it used often as we had years ago. I remember when I first got out of nursing school, we would always have cough medicine that had narcotic in it. It was always locked up. But you don't see that as much anymore. We do see the dextromethorphan that you see there, the DM. That's the stuff they add into your Robitussin, right? Your Robitussin DM, okay, to try to help the cough. Looking at our diagram, you can see decongestants. Yeah, you can do many ways to do a decongestant, right? You can do a nasal spray. You can do an oral decongestant. Working our way down this picture, the mucolytics, see the little hair-like, look like eyelashes, your cilia, and the mucus is kind of covering it. Those cilia will help push out organisms, but sometimes that mucus, again, very difficult. Let's try to thin that mucus out so that, we're able to progress and move it up higher. You'll hear people call it rising the mucus. Get it up higher so you can cough it out. If I've got some inflammation going on in here, again, it's inhibiting my airway, giving me that impaired gas exchange, I'm going to use steroids. Steroids help decrease inflammation. So that's great. And I can take steroids many ways. Oral, IV injection. I can do inhaled. I can do breathing treatments, whether it be an inhaler or through a breathing treatment. So lots of different ways. And as you take a look down here, we can see where our guanfacine is going to help work. So it's just nice to and then your antihistamines underneath. Just really nice to see how the layers of these medications work. So it's not just one area, it's just a multitude of areas. So as we start now, the first of the medications we just spoke of are antitusses. Again, we're going to use that because it's a direct act on the cough center in the brain. Okay, it's going to depress your cough. Again, we can give dextromethorphan in there. We can give you codeine in a cough medicine, the hydrocodone or Vicodin. Yeah, we can do that. If I have an issue that I don't want to give someone a narcotic, again, we're always now with this addiction going on. We haven't seen the codeine in cough medicine as frequently as we had in the past. I don't know where we'll see that now, but the first medication, the Tessalon, the benzonatate, we call them Tessalon pearls. It's a really pretty medication. They look like little baby pearls. They look like little like fish eggs. That one or appetizer. I can't think of it, but these are very tiny. They're pretty. It's like a nice clear pinky white. I mean, it's just a very nice medication. It looks pretty. Again, Tessalon pearls. It helps the cough. Okay. Now, this is a cough that I don't need to worry about producing mucus. This is a very dry, annoying kind of cough. Okay. We're just going to suppress the cough reflex. So we want to make sure we assess that cough just so we know. We flip to the prior slide. Okay, these are decongestants for swelling. Again, now we're going to start putting steroids in your nose. Okay, so we can do that. It's a steroid nasal spray. Again, is it for seasonal rhinitis? Is it for the cold? I mean, obviously these are prescription, okay, where some of the others were over the counter. Again, but we try to get patients to treat the symptoms for these viral things through, make sure you hydrate yourself. Keep a humidifier nearby, a nice cool room, go out, in the cool night, again, avoid smoking, stop smoking during this event, avoid areas of smoke, etc. Again, and if things aren't resolving, then you realize it could be a little bit more than that, and then you do need to seek attention. Now with your nasal steroid inhalers, nasal steroid inhalers, your nasal spray that you're putting in. Again, inflammation, just keep an eye on it. We had a patient in clinical many years ago who was on steroids. I can't remember if it was oral steroids, or was it also the steroid nasal. He had some issue going on. But what ended up happening, remember, steroids mask infection. So what happened was, it wasn't until he started to get dizzy and almost fall that he's like, something's not right here. And when they ended up doing a CAT scan on him, a CAT scan of his head, that he had such a severe sinus infection that it was able to travel to the brain because of the moist environment and because of the use of steroids, masking and decreasing the inflammation. It was able to really fester without a lot of discomfort. That infection, he ended up with a fungal infection on the brain. Okay, so he had to go to surgery. They had to remove that area of the brain that had the fungal infection. Thank goodness he didn't have any deficits following the surgery. But then he had to have a special IV catheter inserted, and we had to give him antifungal medication, and he had to be in the hospital for, oh my goodness, when we had him. Again, this was with the students. He was already in the hospital for a month. Now this gentleman was able to walk and talk. He'd go outside, just get a breath of fresh air, but he was going stir crazy staying in the hospital, and he had to, because the antifungals this was again years ago. I mean, they're so expensive and they can only be given intravenously, and he had a central line, and at the time we weren't really doing these central lines at a home basis, with home health, which we do now. So he was really going crazy having to be cooped up like that. Now we're going to move into your antihistamines as you identify. Now, remember, with some of those decongestants, as we talk about, I mean, I didn't mention, but I'm sure you've seen in the newspapers and on the TV, again, a lot of that stuff is can be made, you can make meth from. Okay, so you have to show your driver's license, and they kind of watch and see how much you do take. So we have to be very careful of that. So that's another thing that goes on with our world of medicine. So now we're going to move on into our antihistamines, and we'll identify with some of that in the way of decreasing our swelling. I'm just going to flip to my pages. I get talking as usual. So antihistamines, they're blocking that chemical release that occurs with inflammation. Okay, histamine is what's causing the inflammation, and it was released during the invasion of some foreign organisms to try to attack and, to kind of clear that up. Again, is it an allergic reaction? Is it related to something that's going on that's invading, which a lot of times that's what's happening with an allergic reaction. You're having invading organisms causing one who has hypersensitivity to react. So if I give you an antihistamine, I'm blocking that. So that's a nice thing. It also will have an anticholinergic and an antipyretic effect, meaning it decreases the itching. So if you take a look and you see the Benadryl here, the diphenhydramine, that over-the-counter medication, let me tell you, that has so many uses out there. It's just phenomenal. But yeah, when one is itchy, right, don't you put on Benadryl cream? If you have some type of skin irritation, poison ivy or something. It's an anticholinergic, right? We think of it as helping the swelling. It's an antihistamine. We even use it for sleeping because of the fact that these medications have a side effect or of being drowsy and sedating. we use it for its effect of making us drowsy and sedated. So a lot of patients do use that just to help them sleep at night. But if I'm going to give this to you, this antihistamine with this anticholinergic effect, remember, we've got to be careful. Urinary hesitancy, anticholinergic effects, that's the stuff that you think of. They give you the anticholinergics when you go to the OR. So remember, when you come out of the OR, you've got to be able to eat, drink, and go to the bathroom. So we've got to make sure we get GI motility back and working, okay, so that you don't end up, vomiting. We want to make sure that you can go to the bathroom, that you don't have any kind of urgency or any problems urinating. Okay, so you're going to have a dry mouth. Again, because that's what we do when you go to the OR. We give you these medications that dry up secretions. So if one is taking antihistamines for a cold, again, keep yourself hydrated. Chew on some ice chips, some hardtack, whatever you need to do, popsicles. Your mouth is going to be dry. And if we're giving these medications to an older individual, keep an eye on them that they're not getting confused. Because again of the drowsiness, the sedation, we don't want them to fall. Okay, we also watch because of the drying up effects, so to speak. We want to make sure sometimes these patients can have a little drop in their blood pressure. So just kind of keep an eye on that. If one med doesn't work, just go to another. And I mean, look at all the medications that you have on the list to pick from. Here's our second generation. These are non-sedating. Okay, when you look at these, aren't these what you think of as allergy medications? You see them, on TV? Yeah, because they are. They're blocking that histamine, that inflammation that occurs secondary to an allergic response. All right, these are nice because non-sedating allows you to function. All right, the other medications, I know, Benadryl, I can't. If I take it after 6 o'clock in the evening, I'm done for the next day. I'm still really drowsy. Everybody reacts differently to medications. And if you have a job and you have to drive, I mean, you cannot be drowsy and ineffective at work the next day. So these are nice that these came around. These used to be, some of these are prescription, but now they're over the counter, which is great. Moving on into our expectorants. There's our guanefacine or our Mucinex. Again, they're helping your cough to be more productive. Okay, they're going to help your cough become more productive. Now, sometimes individuals can cough and cough so hard and so much, they can make themselves vomit. Their muscles will get weak in their abdomen from all the coughing. And when that occurs, that abdominal muscle weakness and soreness from the excessive coughing, especially when the cough is not productive, and it should be because it's a moist, junky cough, as we say, yeah, you do need these expectorants because eventually the patient is going to get fatigued from the coughing. Not only that, the coughing will inhibit their rest, and they need to get rest in order to get better, right? And we say that infection induces the inflammatory processes inducing the sleep cycle, so one can rest so that the body can fight. So it's so multifaceted. You want to make sure if that cough is moist, something needs to come out. Let's get something out if it's not coming out. Let's give them an expectorant. Okay, we've got to reduce the adhesiveness of that mucus. Okay, we've got to get it moving. We've got to get it out. All right. Now, what we want to do is sometimes, like I was mentioning to you before, we may give you medications to suppress the cough. This would be when you get into production of the airway and mucus, etc. in nursing. This is sometimes, again, it's all individually based. You want to make sure the cough is effective and strong enough. There are times where, yes, I can give Robitussin DM. Now, Robitussin is guanefacine, right? So that's an expectorant. That's going to help you rid mucus. But yet the DM, we just said, was a suppressant. This is when we want you to not cough your head off and get physically exhausted from the cough, but we want to rest you so that you can cough. And when you do, it's a very strong, beneficial, productive cough. That would be the time that you need the Robitussin DM. I don't need to cough constantly all day long and tire myself out, but yet I do need to cough, and I have to make it worth my while here. I have to make sure I get something up. So yeah, that's sometimes when we will use the Robitussin DM. Again, very individualized. Every situation's different. These are over-the-counter medications here. go talk to the pharmacist. Explain to them your symptom. Tell them what other medications you're on, and therefore you can then, he'll direct you, or she will direct you to the necessary medication. As you move down to the mucolytics, okay, these are really heavy duty. These are going to definitely break up that thick mucus so you can get that mucus out. So Mucomist is the brand name of it, which is nice because it's in there. But what we see in practice is the acetylcysteine. That's the generic. We can give this to you in a breathing treatment, which is great. Breaks up the mucus. The medication down below, Pulmazine, that's a breakup of mucus. That typically you see with people that have cystic fibrosis, which is chronic, thick, mozzarella cheese-like mucus that they have to constantly, every day, go through hours of get that mucus out in order to be able to function on a daily basis. That we see that used a lot for CF. The acetylcysteine in the hospital setting, that's what we'll see used for in a breathing treatment. Breaks up the mucus, gets the patient to cough it out. That's exactly what we want. Now, one caution when you use this med, again, just like if I give you a diuretic, and I know it's a loop diuretic, I should expect to see an increase in urine output. If I give you a mucolytic, I should expect to see an increase in a thinning of the mucus. If some patient has an increase in that mucus production or that thinning, which is what we should be having, it could actually aggravate the problem. It could bring on a bronchospasm. It could, and when that happens, then there's narrowed airway. I only had that happen once. Patient was totally fine. I mean, they came over to me as an RRT, and then, we took care of that and had them on some assisted breathing devices. They were doing very well. I was thinking, oh, this is nothing. This patient's all taken care of. Well, all of a sudden, around 7 o'clock, I see the heart rate was like 150. I'm thinking, what is going on in there? So I go in the room, and they're the patient's having a real hard time breathing. And I'm thinking, okay, now I have to be a detective. What happened? For the last 2 hours, you've been resting fine. And here I broke it down. I saw the breathing treatment was on. And I looked to see what meds the patient was getting. And that was their acetylcysteine breathing treatment. So what it was doing was liquefying the secretions so much that it was actually causing a bronchospasm. It was aggravating the problem. Again, only time I ever saw that once in all the years I've used that. We've used that on patients. So we had to get it DC'd. Okay, so we had to go through alternate routes to get the patient hydrated and the mucus thin, for them to get it out. So therefore, we couldn't use that medication. So keep that in mind. Always you're the detective. If the patient's condition changes and not for the good, what just happened? What med did I just give, or what med was just given from another discipline within the hospital? Like, what happened? Why are they reacting to that? Another, I don't know if you can call it off-label use, because it's not. We do use it. The acetylcysteine, we can run that in an IV infusion. We can inject that medication into an IV bag of fluid and run it through your vein, through your bloodstream. If you are an acetaminophen overdose, if you're a Tylenol overdose, it will bind and protect the liver. Now, it's very time sensitive. You have to get in the hospital within a certain time frame in order for it to work, and therefore we'll know it's working when I do a blood level of Tylenol and see it dropping. Okay, that's a good thing. But again, this is another antidote. Poison control. We'll be regulating it. So the ER calls poison control. We get that started, and then we may run that for 24, 48 hours. We can also use acetylcysteine. We can squirt it, draw it up. It's a liquid, draw it up. And instead of putting into your breathing treatment, we're going to squirt it into a cup of soda. Now, just so you know, this medication smells like rotten eggs. So if you're going to put it in soda, expect somebody to drink it, you have to put a lid on it. Give it with a straw. And why are we doing that? Well, we have learned that patients with diabetes need to have tests with dye. And we've talked about how kidneys can be damaged from dye. And we know that damage is a greater risk for someone who's a diabetic. And if I give you this in soda, it protects the kidneys from dye if you've had to have a test. So we will do that for about 3 to 6 doses. And if I have the luxury of knowing that I need to give you a test, I can prep you with acetylcysteine prior to the procedure, have you drink some of that prior to the procedure, and then continue to have you drink it for sequential doses following the procedure. And I will protect your kidneys, and you won't end up on dialysis, not from the dye anyway. Because back in the 80s, that was what was happening. We were giving dye to diabetics, and we ended up putting them into renal failure. So there's multiple uses for this acetylcysteine. So drugs that are going to act on your lower respiratory tract. Bronchodilators, okay, anti-asthmatics. Now, this xanthines, we're going to identify those. If you want to just put, what is a xanthine medication? It's actually just like caffeine, okay? It's caffeine. Sympathomimetics, you can understand and appreciate that term now. Anticholinergics, the same. We will also use anti-inflammatories such as the inhaled steroids. We will use leukotriene receptor antagonists or blockers. Leukotrienes are released when we ignite the inflammatory process. So that's taken us back many weeks. So if I'm a leukotriene blocker, you can understand where I will then be decreasing inflammation. And then lung surfactants. Briefly, we'll mention that again. That's just a chemical, a liquid that's necessary for the lungs to fully develop in the alveolar area. And we do see that as a medication used for premature babies. We also will see that used for patients that have certain issues in the adult. But again, we've moved and marketed some other procedures, so we'll kind of speak of those. I like these pictures. They identify where the medications actually work. So you get an idea with the inhaled steroids, how they're up here in the tracheal area. So you see how it's going to help with the mucosa, the inflammation. Leukotriene receptors, again, blocking inflammation. And take a look what's going down now into the lung. A benefit of this medication is it does help. And sometimes when you read in your nursing drug book, they'll refer to it as a bronchodilator because, yeah, it is blocking inflammation and it will allow better air exchange. Here's our xanthines. Again, smooth muscle here. It's relaxing. Okay. And we do refer to that xanthines as a caffeine type of derivative. And then as we take a look over here, further down in our bronchial tree, in the middle, you'll see the alveoli in the circle. You'll see where the anticholinergics can start working, and the sympathomimetics will dilate, again, getting good oxygen exchange. And then down below in the alveolar sacs will be where we'll be using those surfactants. This mixed up with the Atrovent. Okay, so we don't see the brand name anymore, but we'll see the generic. That has helped a lot because Atrovent, albuterol, for some reason they would get that kind of confused. Prevental because Atrovent. Again, but just to kind of take note, remember, albuterol is a sympathomimetic. And as you scroll down, you'll see a lot of the other medications we've addressed that we've maybe given intravenously to increase one's blood pressure along the way. But take a look. These are inhalers. And you know what? We'll call these, some of these medications, that we'll identify them as long-acting bronchodilators or short-acting bronchodilators. And the SABA, or the short-acting bronchodilators, are what we refer to as rescue inhalers. So if you get short of breath, the doctor will teach you, tell you can take like so many puffs a day as needed. Okay, so typically if you get short of breath doing certain activities, you'd say, well, let me take a puff before I do the activity to dilate and open up my airway so I can tolerate the activity and, be able to enjoy life and do whatever it is I wanted to do. With these inhalers, we can also put them in a device called an MDI, a spacer, and it's just a multi-dose inhaler type device, but it's a way that the patient can compress the canister because it's an inhaler. It's a little can. You compress the canister, and they'll be able to take the time to adequately inhale the medication in order to bronchodilate. Now, when do I give all these types of medications? This is the rule usually here. If you've got a breathing treatment going on, which has a bronchodilator, or if I'm giving you a bronchodilator where you can compress the canister and inhale the medication, give the bronchodilator first. Once you've dilated and opened up the pathway, opened up that airway, follow it with the steroid inhaler, okay, or the steroid treatment, because therefore you'll be able to get the steroid further down the bronchial tree to decrease more inflammation, and that will benefit the patient. Okay? Here are the inhaled steroids. Same thing as we talked about with other steroids. We always worry, kind of keep an eye out. It does mask infection. Again, these patients are going to be on these medications for a while. Can it impact their sugar? Maybe not. But the big thing with this one, mouth care. Huge, huge, huge mouth care. Because of the fact it's going to irritate and destroy some normal flora, and it's going to allow other organisms to multiply, and it can really irritate and give you horrible fungal infections in your back of your throat and down your throat. It's the worst sore throat you've ever experienced. Patients will tell me that have had this, they couldn't even swallow their own saliva. It hurt that much. Well, if it's going to give you that discomfort, you're not going to take the med, you're not going to be eating, you're not going to be drinking. So just identify the ramifications of all those things that are occurring. So you must tell the patient they need to good mouth care after. Rinse, brush your teeth, whatever you need to do after you take these steroid inhalers. It is a must. Patients will be fine if they do that and they follow the direction. Okay, they will be fine. It will take a little bit of time for the inflammation benefit to reach its peak, or to let the patient really know. It's not like, oh, I'm going to take a puff and it's all going to be improved. It gets rapidly absorbed, but to reach the peak and the best effect from the medication, from this inhaled steroid, it may take about 2 weeks. Okay, it may take about 2 weeks to get that swelling, that inflammation down, to really identify the true benefit from this particular inhaler. As we look to the next category, which is on the same slide, it's the leukotriene receptor antagonists or blockers. Remember, leukotrienes are necessary for the inflammatory process. So we're going to block it. We're going to decrease the inflammation. We're going to then open up airway, a good thing. You have to be 12 years or older to take it. Okay, this would be your Singulair. Again, these are prescription types of medications. And again, because of the fact it decreases the inflammation, and we're talking about lower medications, when you look this up, you may even see it will be commented that it helps with bronchodilation. Yeah, because it's that far down. It's going to help open up. And then we have our lung surfactants. Again, if we can give you this to help alveoli surface, and again, we do tend to give these meds a lot for little newborns as their ineffective lung development's going on. And that will be all for this lecture. I will get your quiz put on Learn, and you will have up until the start of your last class, which will be May 2nd, when we go over elimination. So you will have close to 2 weeks to listen to the lecture and then to take the quiz. Okay, I'm heading to class now, and then after class I have to go to clinical. So my goal for me is to get your quiz on board tomorrow. So if anybody sees the lecture tonight and listens to it, there will not be a quiz there to take, but my goal is that I get the quiz up for you to take tomorrow. Thank you very much.